Good morning, I'm Peter Lipsky here at the EULAR poster session, and I'd like to tell you something about the poster we're presenting here that tries to examine the kind of care that's given to gout patients in the real world. And in order to determine that, we looked at the Symphony database, which is a claims database based upon physicians' activities, and it involves about 250 million patients. From that, we could identify more than 1 million gout patients, of whom the majority had acute gout based on ICD-10 codes. Some had chronic non-tophaceous gout, some had tophaceous gout, and some had an entity which required multiple visits called uncontrolled gout. The population was pretty typical, what we think of as gout, middle-aged, largely men, and they all had the comorbidities that we understand gout is all about. You can look here at the age distribution and see that the large number of them were beyond 65, and again, mostly men. The interesting phenomenon was who saw these patients. And in each gout category, more than 40% was seen by primary care, either internal medicine or family medicine. A fair number was seen in the emergency room, and a varying number, depending upon diagnosis, was seen by rheumatologists. Less than 5% of those with acute gout were ever seen by a rheumatologist, whereas about 20% with chronic non-tophaceous gout saw a rheumatologist, and about 40% with tophaceous gout at any time saw a rheumatologist. Now, does it make a difference? Well, if we look at things that we consider hallmarks of standard care, whether they had urate testing, whether they were put on urate-lowering therapy, what we can see is that the frequency with which all of these categories were put on urate-lowering therapy had urate testing was much higher if they saw a rheumatologist than if they didn't. The same was true for prescriptions for urate-lowering therapy. Although all of this, we believe, is suboptimal, there's clearly a benefit to the patient if they're seen by a rheumatologist. So we believe these kinds of information can tell us about practice habits in rheumatology and can identify checkpoints that need to be addressed that could increase care effectively and relatively efficiently.